Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins orthopedic surgeon Sabyasachi Tucker will be speaking about revision surgery after a failed previous joint replacement. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching the presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note that this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Tucker to begin our presentation.
Thank you very much, Helen, and good morning to you all. Thank you for taking the time to spend time learning about revision joint replacement surgery and about failed joint replacements. So there are several reasons and several causes when joint replacements fail, and I'll be covering a lot of ground today and then save room for some questions at the end. As Helen pointed out, my name is Savya Tucker. I'm the chair of orthopedic surgery and a fellowship-trained adult reconstruction surgeon specializing in hip and knee surgeries, specifically joint replacement surgeries and failed joint replacement surgeries. This is my contact information for my office, my email, the websites that you can access at any point of time to provide any feedback or ask us any questions or come by for a consultation. I'm primarily located at the Howard County General Hospital in Columbia, Maryland, with privileges up at Johns Hopkins Hospital, Johns Hopkins Bayview in Baltimore, and at Suburban and Sibley in the Washington, D.C. area. So before we begin with what a problematic joint replacement looks like, I wanted to share some pictures of what a normal joint replacement looks like. Joint replacements, for the most part, have become pretty advanced, especially in knees and hips. So the pictures here on the right, if you can see my mouse, on the top right of the picture is a knee replacement implant. The top of the implant is a part that attaches to the thigh bone. The middle part is a piece of plastic that sits between the thigh bone and the leg bone, and the lower part is attached to the leg bone or to the tibia. These parts can either be fixed to the bone with cement, like a grout, or they can be fixed to the bone in a press-fit fashion where the bone grows into the implant. So this is an example of a press-fit implant. At the bottom right-hand side of the picture is a total hip replacement implant. So right here where my mouse is scrolling is the part that goes into the thigh bone. Then we have a pink ball that typically snaps onto the part that goes into the thigh bone. That pink ball is made out of ceramic. And then you can either have a pink or a white structure that snaps in to the metal socket right here. White is typically plastic and pink is typically ceramic. Ceramic on ceramic implants can typically have squeaking associated with them, whereas ceramic on plastic implants are largely quiet. So the standard of care for most of us is to use a ceramic ball that fits into a plastic socket, which then fits into a metal shell interfacing with the bone. And most surgeons in the United States do not use cement to fix total hips to the bone. Some of us will use cement in specific situations. This is what a normal joint replacement looks like inside a patient when you look at them using x-rays. So on the left-hand side of the picture, or the left-hand side of the slide, is a total knee replacement implant, where you can see the part that fits into the thigh bone, and there's a part that fits into the leg bone. On the right-hand side is a total hip replacement, where you see a part that fits into the pelvic bone, which is the socket. You have a ball that snaps into the socket, and then you have a part that sits into the thigh bone. So this is what a normal joint replacement looks like. Now, in terms of placing these joint replacements, we have the advantage of several technological advances. So at the bottom, you can see a computer-assisted system that allows us to place total and partial knee replacement implants. We can also use that for total hip replacement implants, and it resembles your iPhone and the fact of you using something like Google Maps or any kind of map software where it's a GPS system on your smartphone that can be adapted in surgical situations. On the top, you can see that the older technique of doing total hip replacements was to use a mallet or a hammer and put parts into the bone. But now we have a pneumatic gun, which allows us to do that in a very controlled fashion. It's almost like a robotic arm. The feedback that it gives a surgeon is very, very precise in implanting some of these components to help reduce the risk of complications such as fractures, or also reduce things like loosening of the implant. So I'm sorry that my sides seem to be scrolling back and forth, but moving forward, let me discuss some abnormal situations when implants fail. The first reason why implants could fail could be because of fractures. So we're going to draw out some lines. You can see on the left-hand side of your slide, the red indicates the fracture around a total knee implant. Now, this is already a revision type of implant, and there's a fracture around it. And on the left, on the other side, you will see some blue lines, which indicate a fracture around a total hip implant. So this is where the bone is no longer continuous and the implant loosens because of a fracture. Another cause of implants failing could be infection. Now, implants typically are made out of metal and plastic, as we just saw, or they could have ceramic components. Because of that, they do not have a blood supply. And because implants do not have a blood supply, they are at risk of lifelong infection. So if you get a joint replacement, and if you have something like a tooth infection or a urinary tract infection, or a infection in your bowel or any organ organ space, we advise you to seek out medical attention as soon as possible, first from your primary care physician. And if your joint replacement begins to hurt, then an orthopedic surgeon specializing in hip and knee replacement should get involved to try and tackle that infection early on. And again, it's essential to remember that for the rest of your life, because these implants are not designed to fight infections on their own, and you do need an intact immune system to go ahead and fight that infection. With regards to the fractures that we just covered, the implants are very, very strong. These implants are typically made of metals such as titanium, plastics, which are very high-grade polyethylene components. So the modern implant by itself doesn't really break into multiple pieces. So if someone were to have a nasty fall on a hard surface on that joint that's replaced, typically I let patients know that the implant will not break, but the bone around the implant is at risk of breaking because there's a mismatch between the density of the implant and the density of the bone. The implant is more dense and more strong compared to the native bone. Another reason for implants failing could be instability. So on the left-hand side, you can see a knee replacement that has moved out of place, and the knee, as the patient was trying to bend the knee, the implant jumped forward and has become unstable. On the right-hand side, you can see a total hip replacement implant. And in this situation, the ball has popped out of the socket. There are many reasons for instability. Most commonly, it's because of a lack of adequate soft tissue tensioning, meaning that the muscles have to be nice and tight, the muscles have to function well so that the implant does not fail. The implant is initially a load-bearing structure or a load-bearing design, but eventually the surrounding muscles, ligaments, and also the bone have to support the joint and support the implant. So if the surrounding structures fail, frequently implants can pop out of place. There are also unique situations such as patients who've had back or spine surgery. In those patients, their spine tends to be very rigid. And as you go from a sitting to a standing position, or from a standing to a sitting position, there are a lot of forces that go through an implant, typically a total hip implant, and the implant can pop out of the socket. So in those situations, it's important to look outside the box, not just be focused on the hip or the knee, but also assess for extraneous factors like the spine, the ankle, other bones, and other things that make up someone's skeletal architecture. Another factor that can lead to implant failure is loosening. Now, a lot of times orthopedic surgeons are compared to carpenters because the bone is like wood, and essentially we're doing some fancy woodworking to try and fit these implants to the bone. Wood, unless it's a tree that's growing, but wood on its own is not living, so it doesn't change with time. But bone is a living organ, and bone changes with time. So bone either grows with time or it decays with time. Bone can have disease such as infections. Bones can have tumors. Bones are also very dynamic because if we exercise, we tend to strengthen our bones, we tend to strengthen our muscles. But if we're not very active, our bones tend to wither away, and we get conditions such as osteopenia or osteoporosis. So that aspect of fixing an implant to the bone only happens at one point of time when you're getting your joint replacement surgery. But eventually, if that bone weakens, the implant can also loosen over time. Or maybe there's a technical issue in how that implant was placed to your bone. So those are all factors that we need to consider. And here's an example on the left-hand side of a total knee implant. Even though there was cement used to fix this implant to the bone, that cement has shifted around the implant, around the bone, and the implant has loosened over time. Here is an example of a complex total hip replacement, and this patient started experiencing pain in their thigh after several years of this hip replacement because the thigh bone portion, or the thigh portion of that implant, has loosened with time. Then there are issues associated with recalled implants. These implants are, of course, man-made structures, and for the most part, we only implant them once we've looked at research showing that they've been in practice for 10, 15, 20 years in the lab, and finally they've gotten past the FDA clearance process. But despite that, the implants can fail, these structures can wear out, the plastic can wear out, like the example here on the left-hand side. This is a knee replacement in which the plastic has worn out, leading the metal on the top to rub against the metal at the bottom. And you can see that it's created a big cavity at the bottom here. And this is all metal debris in the tissue that's stained dark black. And it can also create this dark black solution in your joint, which can spread to other organs. Now, metal toxicity is a known condition in medicine, but how that toxicity impacts other organs of the body is still up for debate. But that is a concern. So if you have metal ion levels in your bloodstream or a failed implant, they can definitely cause these issues, and they need to be considered for revision. On the right-hand side of the screen is an example of a recalled total hip implant in which there are multiple moving parts. These parts were designed to give surgeons flexibility when placing the implants into someone's body so that we could adjust for their height, we could adjust for various tensions that we had to create in their muscles. But that can fail with time as well because of micromotion and can generate metal ion levels. And finally, the goal that we have, so I'm going to play a video. A lot of times patients come to us with severe deformities like this patient did, and we have to try and correct those deformities and try and make them as neutral with regards to their mechanical axis as possible. But doing that changes the forces that they put in terms of their daily living on their joints. And that could be a problem for these implants over time. So there are several factors that we have in addressing patients with failed implants. The first thing that we as surgeons look at when someone walks in with a painful implant or an implant that makes a lot of clicking sounds or sounds that are similar to their arthritis sounds, which is a lot of grinding, or if we pick up images that indicate that the implant has failed. The first thing that I want to do is I want to look at the operative notes. And the reason for doing that is because I want to find out what type of implant was used, what company makes the implant, because like every mechanical device that we have, which is a non-medical device too, these implants come with very specific instrumentation on how they are placed, on how they can be removed. So we need to understand that. So I encourage patients to obtain their operative notes as frequently or as much as possible. I also like to read through the operative notes to understand if there were any challenges during the initial surgery in placing it, whether there was a lot of blood loss, whether the bone was soft, whether the soft tissues were not responding as they normally would, whether there was a lot of deformity before the surgery, leading to a very challenging reconstruction and replacement surgery. So operative notes are key in understanding all those things. Next, one of the most common reasons for implants failing are still infection. So we want to make sure that we get a full panel of blood work to assess for infections. And there are specific markers in the blood that can clue us in towards infections versus a non-infectious cause for the implant failing. If we are concerned about there being an infection, almost always we will draw some fluid from the joint and send that to the lab to assess for any bacteria that may grow out of that implant or off that joint. Because if we have bacteria, then the protocol on how to treat that failed implant changes drastically, and which antibiotics to use to clear out the joint of that bacteria also change with time. And finally, we have to understand that there are some cases where we will require advanced imaging, such as a CT scan or a CAT scan, an MRI scan, or even a bone scan to understand how that bone is being stressed in relation to that implant and whether or not that bone is failing and the implant is loosening with time. In terms of management, so if we see a patient who's had a fracture either of the bone or a failure of the implant, with the implant actually breaking, usually that necessitates in a revision surgery in which we have to use components that are larger, that are bulkier, and we have to sometimes fix those fractures with other devices such as plates, screws, and wires or cables. So here is an example that I showed you initially of the patient with a fracture where a revision implant has also failed with a fracture. And we went ahead and we converted it to what's called a tumor prosthesis, in which we removed the entire bone that was fractured because that could not support their weight or the implant anymore. And we converted that into what looks like a metal implant that recreates the anatomy of their bone. In terms of infection, we have a very stepwise protocol-driven pathway, and this is evidence-based pathway to get the bone and get the tissues rid of the infection and get them rid of that implant that's infected in order to prepare it for further surgery. So frequently what we will do is called a two-stage process. In the first stage, we remove all the implants and we remove any prior cement that exists in the bone. We clean out the bone very methodically, and we place antibiotics with cement, which is known as a spacer, because it maintains the space in the joint in preparation for a future surgery. So we place this antibiotic-loaded spacer. Along with that, in conjunction with our infectious disease experts, we also give patients intravenous antibiotics. That's an IV line, and we'll give them antibiotics for about 6 weeks to make sure that the infection is adequately controlled or suppressed. After that, we tend to give patients an antibiotic holiday for about 2 or 3 weeks. And during that antibiotic holiday, we go ahead and we test their blood and sometimes even their joint again to make sure that there is no infection that's remaining in there. If the joint and the bloodstream are free of infection, then we can go ahead and re-implant, put in a revision implant in those patients. Now, sometimes based on each individual patient's medical comorbidities or medical history, we may need to give them antibiotics for a long time and maybe even a lifetime to suppress any residual infection that may be brewing. With regards to stability, so this is the example of a patient in which the ball had popped out of the socket. In this case, the reason why this happened is because the socket had shifted during surgery and when the patient started putting weight on that leg. So we had to fix that socket more rigidly to the bone. And you can see on the right-hand side, we've now used several screws to fix that socket to the bone, just because that bone didn't play out to be as strong as expected as his other hip replacement. So in that situation, we have to add more hardware. We sometimes have to change the way that hardware is positioned so that instability problems don't occur. And like I said, we have to think outside the box and look at their spine sometimes to make sure that the spine is not playing a role in the instability. And if so, how can we work in conjunction with our spine surgeons to enable adequate balance for patients? In terms of loosening, so this is the example of the patient that started having thigh pain while putting weight, indicating that the implant was loose after several rounds of testing. And in this situation, we had to go in and remove the loose part from the thigh bone. And even though it indicated itself to be loose on imaging and clinically for the patient, it wasn't grossly loose that we could just rip it out of the bone. So we had to cut the bone very methodically and then put a brand new implant in there, as you can see on the right-hand side, which is a longer implant that engages a bigger area of the bone, and then had to use cables to wire that bone back together so that the patient can put weight on it. Now, in this patient situation, there was nothing wrong with the socket part or with the other screws up there, so we let that be. This is the example of a recalled implant which generated a lot of metal debris for this patient. And we made sure that the patient did not have any source of infection or any infection brewing in the joint before offering them a revision. And we removed the recalled implant. Typically, what happens with the recalled implant is that we send that to our hospital pathologist as a permanent specimen. The pathologist evaluates it. And in many situations, the patients decide to pursue legal options to understand why the implant failed and to discuss that with their respective companies that designed that implant for them. So we like to keep these implants with the pathologist for further retrieval if need be. And in this situation, the patient ended up with a very successful revision surgery. Again, the socket part was well fixed and did not need to be disturbed, and we only went ahead and changed the part in the thigh bone. So, in summary, revision joint replacements are challenging in nature, but at the same time, even though they're challenging for the surgeon and for the patient, in many cases, they're extremely rewarding so that patients can get their quality of life back. We can restore their function, we can restore their activity, and overall generate a happy outcome. However, to do these surgeries does require multidisciplinary care. You need to have, in many times, infectious disease experts, vascular surgeons if the implants are near some very critical blood vessels. We sometimes need to use plastic surgery in order to help close some of these complex knees or hips, which have had years worth of damage. So using kind of those resources does help ensure successful outcomes. Every single revision situation is unique in its own right. No two people typically fail for the same reasons. So we have to understand and we have to calculate a very customized risk to reward ratio to really assess how much risk are we going to undertake and how much reward can we normally get from that revision procedure. And doing these revision procedures does require specialty training. So as I mentioned, I am an adult reconstruction surgeon. I have fellowship training in hip and knee reconstruction, and we have an entire division of about 6 surgeons in our department that have been specifically trained for hip and knee reconstruction procedures who perform primary procedures, but also revision procedures. So this does require adequate training and experience and expertise in performing these types of surgeries. And finally, what tends to happen is joint replacements are becoming more and more common. By 2030, we're going to see over a 600% rise in the number of patients getting joint replacements and also revision joint replacements because patients are living longer, they are more active. The implants can also have certain failures associated with them, as we discussed. So a lot of surgeons want to go ahead and do these procedures for their patients. And a lot of patients request them too, but they do require some heavy lifting if they fail and when they fail. And that's when having this multidisciplinary subspecialty based experience really matters. With that, I thank you very much for your attention. Once again, this is my contact information with my office phone number, my email, and the websites by which you can reach me. And we have our appointment lines noted here as well. And I'm happy to take any questions. So the first question that Helen posted to me is that there is a patient who has an 8-year-old total knee, which is frozen at about 55 degrees because of scar tissue. Is revision surgery a good option? That's an excellent question. So the normal range of motion of a total knee goes from full extension, which is known as 0 degrees, in which the knee is completely straight, to at least 90 degrees of bending, because that's what you need to climb stairs, get in and out of a car. Now, we ideally like this to be to 120 degrees. So we like it to be even further. I'm sorry about that. We like it to be even further so that we can go ahead and provide patients a very functional outcome. 55 degrees is definitely stiff. At 8 years, that's surely stiff. So I think that we need to think about why it's stiffened and why there is scar tissue. In terms of nerve freezing before a knee revision, that's the second question. So nerve freezing happens when there is a lot of pain. And we sometimes recommend patients to get what's called a radio frequency ablation, in which we can use ultrasound to work around the nerves and quote unquote freeze them to make them less symptomatic and less painful. If pain is not an issue, then I think that nerve freezing is really not something that we need to consider. If pain is an issue and if pain is what's leading to stiffness, it may be beneficial to go ahead and freeze those nerves and reduce the pain. And then the third question is, can anything be done if my hip replacement repeatedly gets dislocated? That's again proving to be a very challenging issue for a lot of patients these days. So I think in most cases, we have to assess you not just from the hip perspective, but from a muscle conditioning and muscle strengthening perspective, and also on how your spine plays a role in that hip replacement. So looking outside the box a little bit and assessing what factors may be causing that hip replacement to dislocate would be important. The fourth question is, if your x-ray shows a normal implant, but you are in pain, how can a doctor determine what's going on? That is an excellent question. So typically we say that knee replacements are about 85 to 90% successful, and hip replacements are upwards of 95% successful. There are about 5 to 15% of patients, all comers throughout the world, who still have pain associated with their implants. So when someone like that presents to our office, it's of course very challenging and frustrating for that patient, because they've had a thought that they're going to have a very fruitful, active lifestyle. In that situation, we still go through the same regimented fashion to figure out whether there is loosening, whether there is an infection, whether there's a fracture, whether there's an implant-related recall, all of these factors, because sometimes we can find a hidden factor that just wasn't looked at or wasn't considered. So I encourage you to seek out assistance in that situation to find out what that cause may be. And if there is no cause, then we can discuss pain management strategies to help reduce the pain in that joint. Number 5, is being on long-term antibiotics a major risk for a compromised immune system? So immune systems can be compromised for various reasons. A lot of patients will have things like kidney transplants, liver transplants, heart or lung transplants, and they still have arthritis, which necessitates them getting a joint replacement. In those patients, they're always at higher risk of implant complications such as infection. And sometimes we recommend doing an extended course of antibiotics when we do the surgery. Sometimes they require antibiotics for the rest of their life if they develop an infection. So yes, antibiotics can be risky and antibiotics can cause a problem to the rest of your body and the rest of your organs. And in those situations, we closely work with infectious disease specialists to guide us on the appropriate antibiotic therapy and also to reduce any risks associated with those antibiotics. Okay. So I have been requested to just share my screen for a second and leave it posted for the last slide. So I'll just go ahead and do that. So I hope that my screen is visible, and I'm going to try and move the chat box so that I can read while you have access to our phone numbers. Question number 6. If an implant has loosened, should a patient have an MRI to better determine and confirm that loosening? Great question. I think for the most part, I would encourage you to seek out care from your orthopedic specialist to determine why that implant has loosened and if it has loosened. Frequently, MRI scans can create a lot of scatter, or the metal implants can create a lot of scatter when getting an MRI scan. So we may not be able to completely rely on an MRI, but I leave that to the judgment of your orthopedic surgeon evaluating you. My preference happens to be the bone scan, where we can see subtle changes in how the bone responds to the implant. And again, that bone scan is valuable typically after 2 years from their primary surgery. Question number 7. I have a lot of crunching in my replaced knee and pain when moving. My leg around the knee also feels stiff when I walk. Any thoughts? So, a lot of times patients who have arthritis will detect stiffness associated with their joints. And they will also report that the stiffness can be weather related, specifically when the weather is damp or there's a big transition into cold weather. And we've noticed that based on pressure differences in the atmosphere, patients can experience more or less stiffness associated with their joint. So if you have stiffness and if it's related to lack of motion, then that should be assessed. But symptoms of stiffness after joint replacements can persist. And I typically encourage patients to just move in one position before they start walking so that that stiffness gradually resolves in the first few steps. With regards to crunching, knee replacements and hip replacements are, of course, foreign objects and foreign devices. And sometimes just the act of the metal rubbing against the plastic can create crunching and can create the sensation that things are cracking around in there. If that is not associated with any implant-related failure, then that can be normal in some situations. If it is associated with implant failure, then that needs to be looked at more closely. Number 8, after a joint replacement, is it still a good protocol to take antibiotics before having dental work and other surgeries to prevent infections? Excellent question. So the most recent American Dental Association guidelines typically don't recommend using antibiotics for routine procedures like cleaning or just simple dental procedures that do not involve deep work like root canals and things of that nature. However, there are some patients that are immunocompromised that will benefit from getting antibiotics, and that's an individual case-by-case discussion that you need to have with your dental provider and your orthopedic surgeon. Number 9, do you have any experience in sudden pinpoint pain on the top of the knee while seated and severe pain with sitting and standing 3 months after a hybrid knee implant? Great question. That can indicate sometimes that there's a compromise of their extensor mechanism, so meaning their quadriceps tendon, their kneecap, or their patella. There may be some partial tearing of some of the tendons involving that, or the fact that sometimes that the kneecap is either too thick or too thin, and the quadriceps muscle can be too strong or too weak, typically too weak. causing pain in those situations. So again, that's something that needs to be evaluated in the office more clearly. Number 10, are there issues with cobalt joints for knee replacements? Great question there. So a lot of patients seem to be having allergies to metal, or at least hypersensitivity to metal. Knee replacements, typically the part that goes into the thigh bone is made out of cobalt chromium, and the part that sits in the leg bone is made out of titanium to absorb the forces a little bit better and make it more friendly. But if patients report to us that they're allergic to these metals, and specifically that metal is a nickel in the cobalt chromium components, then we test them. You can test them with metal allergy testing with an immunologist. And if that comes back positive, we have nickel-free products that are made out of ceramic, oxidized ceramic, and also out of titanium. Number 11, can you simply replace cement that has loosened without removing the implant? Typically not. It's very hard to access that cement mantle without removing the implant. But what we can do is, if your cement shows cracks in it, we can usually fill it up with another layer of cement without removing the cement from the bone, and then place a smaller sized implant into that cement mantle. Number 12, how do previous reconstruction surgeries, such as a Hauser procedure to stabilize patella dislocation, affect future knee replacement surgeries? So our joints tend to be very, very finely tuned structures. And by having a lot of previous surgeries, that can create increased stiffness, increased instability, increased risk of implant loosening, and increased risk of implant infection in them for the future. So unfortunately, it's very hard to go back and undo what's been done in the past. But prior surgeries does lead to lower or worse outcomes with future joint replacements. Number 13, I have a 7-degree lateral motion in my knee replacement. It does not hurt, but it affects my ability to walk correctly. Is replacement the only solution? So I'm guessing that you have had a knee replacement and you're having some increased looseness in it as you walk. So sometimes when that happens, if we can address it with a brace or external devices without having to undergo a revision, and if that provides adequate comfort and support to you as you do your activities of daily living, then you don't need to undergo a revision, especially if you're not having pain. But if there is a mismatch, or if their implant is not balanced well, that can lead to premature implant failure. So getting regular checkups with your orthopedic surgeons would be my advice. If an implant has loosened, should a patient have an MRI to better determine and confirm that loosening? I think this question's come up again. It depends on what has been detected as the cause for that loosening with your orthopedic surgeon. And typically my go-to in those cases is a bone scan, typically after 2 years of implant placement. Number 15, is snapping hip syndrome considered a joint replacement failure? How is it treated? Typically not. Snapping hip syndrome is when the muscle, which is typically your abductor muscle or your IT band, snaps around the bone around your hip replacement, or around non-hip replacements as well. It just kind of snaps around the bone. People can have it without hip replacements as well. In that situation, it may be because of some specific bony architecture, or the fact that that muscle has become very, very tight. And usually we recommend patients using physical therapy services to help relieve that snapping hip syndrome. Number 16, a patient reports that they've had a revision hip replacement 3 years ago and their thigh is still in pain. I am told it takes time, but how long should I wait to see an improvement? 3 years is definitely too long. I would say that within the first year is when you should see resolution of those symptoms, and typically it's within the first 6 months, but 3 years may be too long. So you may need to get further advice on why that's still hurting. Number 17, how do we determine or definitively determine leg length differences and what can be done about it? So this is pertaining mostly to total hip replacements. What happens in hip replacements is to keep the implant stable, we have to make sure that we tighten up the hip musculature, typically the abductor muscles, so that the hip doesn't pop out of place. And we can do this by changing the orientation of the components and also the size and length of the components to make the leg slightly longer if need be to provide that stability. If there's a very big difference in your leg lengths, typically 2 centimeters or more, that can become problematic and your back can hurt or your other joints may start to hurt as well. In that situation, we typically get long length x-rays with you standing and measuring the leg lengths. We also do a clinical measurement. We do measurements while we're performing the surgery to make sure that the leg length differences are minimized. But the goal of a hip replacement is to provide patients with a stable, pain-free joint. And those are the first two goals. And if leg length similarity comes as a part of that, that becomes the third goal. Number 18, what is the best way to determine a quadriceps tendon tear? The best way is to look at your knee and determine if you can raise your knee against resistance or even raise your knee against gravity without any other types of resistance. If you can do that, you have some of the fibers, if not all of the fibers of your quadriceps intact. If you cannot do that, you have a quadriceps tendon tear. And subsequently, when you are examined by your orthopedic surgeon, they may be able to detect that clinically. In addition to that, they can look at that on x-rays where the height of the kneecap comes lower than its normal position. And sometimes we need to get an MRI or an ultrasound to confirm that tear as well. Number 19, my wife had initial knee replacement surgery in November of 2021 and a revision in July of 2022. So within about 7 or 8 months, they had a revision surgery. She is still in pain, but no infection. Any suggestions? That's a tough problem that your wife is going through. So I'm sorry, first of all, for them having to deal with this situation. I'm glad that there is no infection, but we would have to look at records. We would have to look at the implants to further determine the cause of the pain. Sometimes if the implant by itself doesn't have any failure associated with it, or the bone doesn't have any failure, there can be painful neuromas, small little nerve bundles that can be inflamed and can cause pain around the joint capsule, which leads to a lot of discomfort and inability to perform tasks. In those cases, we could recommend a nerve ablation to try at least to quiet down those nerves. Number 20, what is involved to have the patella resurfaced? My 10-year-old left knee has no problems, but my 9-year-old right knee replacement is bothering me. My surgeon said they should have resurfaced the patella, but my left knee is fine, and it's just the right knee that's a problem. How long is recovery if I have the patella resurfaced? Is it major surgery to resurface the patella? So what's happening is that there's a debate in our field on whether or not we should also resurface the patella, meaning cut a little portion of the patella and put a plastic button on it. The advantage of doing that is that when you get a total knee replacement, all the parts are then replaced. So if there's any residual pain, typically it's not because of a part that was not resurfaced or a part that can become arthritic. The disadvantage of doing that is sometimes the kneecap can be pretty thin after we've made that cut or we've made that resection. And even if we reinforce it with that plastic button, if someone were to have a fall or some other injury and that mechanism were to fail, the kneecap were to fail, then the further recovery from that type of injury could be pretty devastating for patients and their families alike. So a lot of us have now gone to not resurfacing the patella because we don't believe that the patella is a major source of pain. In terms of resurfacing the patella after you've had a total knee replacement, so several years after, the surgery is considered to be a big surgery because you still have to go through some of the scar tissue that is formed. You still have to open up the surgical incision, meaning that you're still at risk of infection. So if you're not having terrible pain, I don't think that you need to go ahead and resurface the patella. A large portion of why to resurface the patella may be because of persistent instability. So that's something that should be diagnosed a little bit before offering revision surgery to you. Number 21, can you comment on the limits to range of motion subsequent to the use of a constrained liner implanted during revision as a consequence of failure? So this was a dislocation of a dual mobility implant. I am unsure of what normal activities I need to avoid because of reduced range of motion with the constraint liner. So this is a very high level question. A dual mobility implant is one that's used in total hips in which there is a small ball that fits into a large ball that fits into an even larger ball that fits into the socket. So it has two modes of articulation or two places where the ball goes into a socket. And for it to fail requires usually a failure at one of those or both of those. When you have an intraprosthetic dislocation or dissociation, meaning that the smallest ball typically comes out of one of the other balls that make up the dual mobility implant. And what your surgeon has gone ahead and done and given you a constraint liner, which is like the rings of Saturn around the plastic part, that does give a certain limitation to motion. So typically I advise patients that no bending more than about 90 to 100 degrees would be advised in that situation, at least early on after a constraint liner. No hyperextension, so no standing straight and moving their leg way back to try and achieve a gymnast's pose to prevent the hip from popping out of the front. And basically no forceful motions of the hip. Now, if you're able to perform high bending and straightening activities and a lot of maneuvers of the hip without pain and without instability, you can go ahead and do that. But if you start noticing pain with gradual range of motion into those extremes of bending, extremes of straightening, extremes of motion, then you probably should not do that at the risk of dissociating or dislocating from the constraint liner. Here's our last question. So the patient reports that they've had knees replaced in 2012 and 2015. They have loosened and become very painful. The patient's 67 years old. How long could I expect revision implants to last? Great question. So it sounds like your primary implants have lasted you only about 10 or 12 years, and they have already failed. Most of these implants these days are lasting anywhere between 15 and 20 years. Some studies also report implants lasting for up to 25 or 30 years. So definitely it sounds like in your case, the implants have failed a little bit on the early side. We would have to assess and see what the reasons for failure were. And if your bone stock is good and you do not have an infection, typically the revision implant should be adequate for at least another 15 or 20 years if done appropriately. So I'm glad that we had a chance to go over a lot of important concepts with failed joint replacements. And the questions that were posed were all extremely well researched and extremely interesting. And I'm hopeful that we were able to provide some valuable information to you. Once again, these are our phone numbers up on the screen. So if you have any comments, any suggestions, and if you'd like to come and schedule a consultation, please don't hesitate to get in touch with us. Thank you very much.